Thanks a lot, Fadi. So good morning. I'll give you guys just a quick breakdown. What I do, I'm a pharmacist at Center for Addiction and Mental Health, and I work on a unit called the Medical Withdrawal Services. Thanks a lot, Fadi. So good morning. I'll give you guys just a quick breakdown. What I do, I'm a pharmacist at Center for Addiction and Mental Health, and I work on a unit called the Medical Withdrawal Services. It's a 12-bed inpatient unit where we provide medically supervised withdrawal management, and we typically treat patients with substance use disorders, specifically alcohol use disorder, opioid use disorder, benzodiazepine and sedative use disorder, and polysubstance use. So typically, patients stay there for an average of approximately 7 to 10 days, and then they're discharged back to the community or a residential program afterwards. So I'll be giving talking for two sections. The first section we'll go over today is called Strategies for Engaging the Patient at the Pharmacy. Let me see. So the learning objectives for this section are to describe public health risks associated with opioid use, risks and protective factors for developing opioid use disorder, describe treatment strategies for opioid use disorder, consider cultural differences when discussing addiction and use of methadone and or buprenorphine naloxone with patients, communicate effectively with patients using MI. So with regards to opioid overdose risk, very simply, we know that the risk of opioid overdose increases as the dose increases. There's also an increase of overdose risk with a history of substance use disorder, or obviously active substance use disorder, and concurrent issues also. So if you look at the chart right next to on this slide, you can see that when the opioid dose is relatively low, so if you look at the bottom left corner, you can see less than 20 milligram morphine equivalents per day. The risk of fatal overdose is approximately 0.1% per year. But as the dose increases, and in this case, if it's over 100 milligrams per day of morphine equivalents, it can increase up to 0.23%. So again, just to keep in mind, takeaway basically is that as you increase the opioid dose, there's a higher risk of overdose death, accidental overdose, opioid overdose. So this is a chart just showing a percentage breakdown of where patients obtain their opioid medications or pain relievers. And again, if you look at this chart, you can see here that obviously the biggest component where it says 54% is the green section, where it shows that they were obtained from a friend or relative for free. Again, also, if you combine it with a couple other sections, if you look in the 12.2%, you can see that was bought from a friend or relative. And then if you look at another section, 4.4%, says that that percent is taking from a friend or relative without asking. So again, if you combine all these sections up, you could see that over 70% of people are obtaining their opioids and pain relievers from friends or relatives. Again, may not be what you think. If you look at people obtaining them, maybe possibly purchasing from other people that they don't know from the street or double doctoring. That's not the most common way that people are obtaining their opioids. So again, why are we concerned about the opioid use? In 2018, there were 4,460 apparent opioid-related deaths. The vast majority, 94%, were unintentional. And we could see now that as time is going on, there's a greater amount of fentanyl and fentanyl analogs, which are primarily responsible for a lot of these overdoses. And again, you could see from 2016 to 2019, there were over close to 13,000 Canadians died from an apparent opioid-related overdose. What causes addiction? It's a mixture of factors which include the neurobiology, genetics, adverse childhood experiences, mental health issues, stress, and also cultural differences. So when we're looking specifically at youth, risk factors for substance use and addiction in youth can include things such as family history of alcohol or other substance misuse problems, poor school performance, poverty, stress, not fitting in socially, a history of emotional, physical, or sexual abuse, and experiences of discrimination or oppression. Some protective factors for addiction include having a good or positive role model, so that could be a parent, a relative, or a teacher. Strong attachment to family, school, and community, having goals and dreams, and being involved in meaningful activities such as structured sports, music, and volunteer work. So treating opioid dependence, the benefits include less illicit drug use, better general health, better access to healthcare, greater ability to acquire and maintain employment, less reliance on public assistance, and overall better social functioning. Also, there are less spread of infectious diseases, fewer deaths, less violence, less theft and property damage, safer communities, lower health, law enforcement, and social assistance costs. So when we're looking at harm reduction, there are two ways we can look at harm reduction. So we can look at harm reduction through the patient's perspective, and we can also look through it through the system perspective. So when we're looking at opioid use harm reduction through the patient perspective, there are a number of things that we can recommend for the patient. Number one would be a safer route. So an example of that would be if a patient is using IV injection for their opioids, we can offer a safer route of maybe chewing their tablets, swallowing their tablets ideally. So these are options of harm reduction we can offer to the patient. Another option is substituting their drug of choice. So again, if we know that patients are obtaining their opioids illicitly from the street, using fentanyl, which is obviously very dangerous and a high risk of opioid overdose, we could maybe suggest that they use a safer supply or prescription medications as their drug of choice over fentanyl. Reducing their quantity or frequency. So again, if their patients are using IV opioids, they're typically using 4 to 6 times a day. So we could, if we switch them over to oral tablets, they may reduce their frequency of use throughout the day. And then also if they're using, let's say, a couple points per use, so up to like a gram a day, we could recommend that they try to slowly reduce their quantity over time and taper their dose. Also, never sharing. So we always recommend never sharing, avoiding mixing drugs together. Mixing drugs when combined, opioids when combined with other substances such as benzodiazepines or alcohol, the increase of opioid overdose increases dramatically. So again, if they're going to use substances or drugs, we recommend just using one. And then also, we always recommend never using alone. So we always recommend that if you are going to use, ideally use with another person. If they're using with another person, obviously you're not counseling them to both use at the same time, but one person uses and the other person is there to monitor them if they have any signs and symptoms of opioid overdose, then they can offer some help. Another option, if there's nobody available for them to use at the same time, then they can maybe sometimes contact, message a friend and let them know that they're going to be using. And so the friend can maybe call them in a few minutes just to follow up and make sure that they're okay. When we look at harm reduction for the system perspective, we have options such as opioid replacement therapy. So obviously those are options such as Methadone or Buprenorphine and Buprenorphine Naloxone. We have needle exchanges. So again, if they're using IV, we can offer them clean needles. And also, if these services are available in your community, you can give them information about safe injection sites and overdose prevention sites. From the pharmacy, we can always counsel patients and provide take-home Naloxone kits. So those are the opioid overdose prevention kits, which are available either as injections or nasal sprays. And then specifically, I guess, for fentanyl patches, we have the Patch for Patch program where patients are returning used fentanyl patches back to the pharmacy. So when we look at treatment options, we have structured opioid therapy. So what that means is there are options that we can provide for the patient, which are a little bit safer. So those can include a gradual dose reduction. So if a patient is still using opioids, we can offer options to gradually reduce their dose over time to reduce their opioid overdose risk. And we can also provide information about opioid rotation. So we know with opioids, when you switch from one opioid to another, there is incomplete cross-tolerance between the two opioids. So for example, if a patient is using hydromorphone, if we switch over to a different opioid such as morphine, we can often reduce the total morphine equivalent dose, so the total overall dose of their opioids, by just switching from one opioid to another. When we're looking at opioid agonist therapy, there are options. We have Methadone and we have Buprenorphine Naloxone. And then we also have Buprenorphine, which is the subcutaneous injections also. So a little bit more about the structured opioid therapy. When we're selecting opioids, we want to choose for the total dose. We want to make sure if this is a new start and they haven't been on opioids in the past, we want to make sure that the morphine equivalence is less than 50 milligrams per day. And then also when we're dispensing opioids, this is very important. We want to make sure that we're not dispensing large quantities at one time. So again, depending on the patient, depending on the indication for the opioids, we can either dispense daily, observed, or dispense daily, a few days supply at a time, or up to a week or maximum 2 weeks at a time, again, depending on the indication and the use for the patient. In terms of monitoring, we have different ways to monitor their compliance with the opioids. So obviously, we have access to urine drug screens. So those are tests that we can do, again, depending on their length of treatment. We can do it as frequently as we feel necessary. We can ask for pill counts and patch returns. So these are good tools to monitor if the patient, if you're concerned about the patient using the opioids appropriately. If they're being dispensed a week or 2 weeks at a time, you can ask for them to bring back their opioids sometime during that time frame, and then do a pill count to make sure that they have the appropriate amount of opioids remaining. And then, as with kind of any medication, you want to evaluate the effectiveness of that medication, in this case, specifically opioids. So you want to evaluate that with the patient frequently, ask if they're having any side effects, any adverse effects, and always weigh the risks versus the benefits of the medication. So the next slides are just a chart comparing methadone versus buprenorphine naloxone. I won't go through it in great detail since I know this has been covered already. I'll just make a few points. So when we're looking at the effectiveness of methadone and buprenorphine naloxone, I would say they're both considered the first line agents for opioid use disorder. So again, these are two good options. In terms of availability, they should be fairly widely available throughout Ontario. So again, patients should have relatively good access to both these medications. So the primary differentiating factor between methadone and buprenorphine naloxone is the safety component. So we know that in terms of efficacy, they're fairly similar. However, in terms of safety, buprenorphine naloxone is considered much safer than methadone, obviously because of its partial opioid agonist activity. So all things being equal, when we look at the guidelines, specifically the CRISM Canadian guidelines, they do recommend buprenorphine naloxone as the first line option versus methadone due to its higher safety profile. Also, a few differences are the initiation. So with buprenorphine naloxone, obviously we know that they have to be opioid free for a certain amount of time to prevent precipitated withdrawal. However, once they are started, we know that we can easily titrate up the buprenorphine naloxone dose much quicker. So they can be at a stable dose within 1 or 2 days. Versus with methadone, we know that we have to start at a lower dose, so up to maximum 30 milligrams, and we can only increase doses at specific amounts and time frames, which again makes it a little bit more difficult for methadone for patients to be able to get up to a stable dose quickly. Side effects, again, are fairly similar between the two. However, with buprenorphine and naloxone, generally it's considered that there are similar side effects with methadone, but typically less severe. So when we're looking at signs and symptoms of opioid withdrawal, this is just a list of the physical symptoms, physical, psychological, and physical signs. So again, you may or may not be familiar with these. Typically ones that I attribute mostly to opioid withdrawal would be patients are going to have anxiety, restlessness, dilated pupils is a big sign that you may see, and goosebumps and yawning, and those are really telltale signs of opioid withdrawal that you may see in your own practice. So opioid withdrawal complications. We know that when a patient or a person is going through opioid withdrawal, it is not directly life-threatening, meaning that they are not going to die from going through opioid withdrawal. However, we do know that opioid withdrawal is incredibly uncomfortable, and people fear opioid withdrawal often more times than they fear the risk of opioid overdose. So it's important not to minimize opioid withdrawal and to acknowledge it and understand that patients are very, very afraid of going through opioid withdrawal and severe opioid withdrawal. Also, we're aware that opioid withdrawal can potentially be life-threatening in a few amount of cases. So specifically when we're looking at pregnant women, if a pregnant woman goes into opioid withdrawal, they're at risk of having a miscarriage or premature labor. So again, it's potentially life-threatening to the fetus. And then we also know that indirectly, some patients may be so afraid of going through opioid withdrawal, as I mentioned, they may be at risk of suicide or overdose from opioids as a result of trying to avoid going through severe opioid withdrawal. So these are just some prescriptions and medications, over-the-counter medications that may be helpful in managing some opioid withdrawal. We have over-the-counter medications such as analgesics, acetaminophen, ibuprofen, naloxone kits are available. Prescription medications such as clonidine. We generally want to avoid the use of any sedating medications. So something like dimenhydrinate for nausea and vomiting is not something that we typically recommend. However, we sometimes offer them oral ginger tablets if they're having some mild to moderate nausea and vomiting. in terms of sleep hygiene, we know that patients going through opioid withdrawal are having difficulty falling asleep and often experience insomnia. We can always counsel them on appropriate sleep hygiene. And in terms of medications, again, we want to avoid medications with a high abuse liability or dependence. So anything like benzodiazepines or Z drugs, we avoid using. Alternatives that we do use would be something such as over-the-counter medications such as melatonin, or low-dose prescription medications such as trazodone or mirtazapine. Okay, so in terms of determinants of health, these include things such as income and social status, education, employment, social environment, physical environment, gender, and culture. So when we're looking at different cultures in Canada, it's important to know that immigrants represent up to 20% of all Canadians. There are greater than 200 ethnic groups, and there are over 200 languages reported from the 2011 census, and culture is important for effective health promotion. So when we're looking at ethno-cultural communities, we know that they are vulnerable to mental health and substance use issues. They lack knowledge about mental health and medications and drugs. They're often less likely to receive care, and there can potentially be a mistrust of mainstream service providers, and there's often different beliefs and different communication styles. Again, they may have experienced may have different experiences from their own country of origin. Often there are cultural barriers, not just literacy, and often there's diversity within a cultural group and difference in perception. So when we're looking at substances, one example is alcohol use within cultures. So again, we have to take into account that different cultures have different ideas in terms of substance use. So it's important to make sure that you're comparing apples to apples. So then we all know that there are the standard drinks, which include 12 ounces of beer, which is 5 ounces, equal to 5 ounces of wines, or 1.45 ounces of spirit. So again, when people are describing their alcohol use specifically, it's important to kind of get a good idea of how much they're actually drinking. And again, there are things such as at CAMH, we have the low risk drinking guidelines. So these guidelines are specific for men and women. So when we're looking at men, these drinking guidelines include no more than 15 standard drinks per week, and in one sitting or one day, no more than three drinks per day. And again, when we're talking with women, it's the same idea, no more than 10 drinks per week for women and no more than 2 standard drinks per day for women. So again, if a patient is saying they're drinking 1 cup or 1 glass of wine or beer, again, it's important to get the appropriate measurement so you know exactly how much they are drinking. When we're looking at barriers to treatment, there are many barriers, including stigma, marginalization, healthcare and services may not be culturally appropriate, low health literacy, the treatments and healthcare may not be available in their own languages. And in terms of services, there are often long wait lists for OHIP services, and also many services may not be covered by OHIP. So in terms of enhancing access, we want to involve community-based peer workers, and they can help to assist with language, health promotion, and system navigation. Provide flexible hours, provide services that are accessible by public transit, and have childcare services and services that are culturally sensitive to the specific culture. Working with ethnocultural communities, we want to actively involve community members in conceptualization and development, and also make sure to include mixture of ages, gender, socioeconomic class, and length of residency in Canada. We want to make sure that group meetings are held in convenient locations, provide ethnic mass media for health promotion so we can advertise on local TV and radio stations specific to the cultures. Use appropriate images depicting people targeted, and have brochures in appropriate language with simple messages. So why do people change? If you treat an individual as he is, he will stay as he is. But if you treat him as if he were what he ought to be and could be, he will become what he ought to be and could be. So what helps people change? People are generally better persuaded by reasons which they have themselves discovered than by those which have come into the mind of others. So these are just a couple quotes and describing the ideas behind the next section we're going to talk about, which is MI, or Motivational Interview. So what is MI? MI is a collaborative, goal-oriented method of communication. It focuses on the language of change, and it uses the patient's own strength and motivation to achieve their specific goal. And MI is useful for patients when they have difficulty making changes and prefer staying in their current situation or the status quo. So just a bit of background regarding MI. It began in 1983, and it specifically started in the realm of substance use disorders, or specifically alcohol use disorder. It eventually expanded to other substances, and then other health issues also. So it's used with patients with diabetes, hypertension, eating disorders, gambling, dual diagnosis, and weight loss. And it is currently practiced in over 45 languages. So these are the elements of motivational interviewing, and you can see it's based in the shape of a pyramid. So the key point is these are all important elements of MI, with the foundation being the spirit of MI. So the spirit of MI is basically describes the collaboration. So the collaboration just means that you are working together with the patient. You are not telling the patient what to do, but you guys, the two of you are working together, and the patient is their own expert. Evocation, so the patient has the motivation and resources within themselves. And finally, autonomy. So the autonomy just means that the patient has the right and capacity for self-direction. So again, you are working with the patient, and the patient has the autonomy to make their own decisions. So even if the patient sometimes may make a decision that you don't necessarily agree with, you are still working with the patient and guiding them. So in terms of the principles of MI, principles include expressing empathy, developing discrepancy, rolling with resistance, and supporting self-efficacy. And the goals include building rapport with the patient, going over pros and cons of their decisions, respecting patient autonomy, and communicating that the patient is capable of change. So in terms of expressing empathy, we know that acceptance facilitates change. So we want to use something called reflective listening, which is fundamental in MI. And we're understanding the emotion behind the resistance, and also acknowledging that sometimes the ambivalence of the patient is normal, and we're working with the patient in terms of their changing their ambivalence. So develop discrepancy. The patient, rather than the healthcare practitioner, brings up reasons for behavior change. So again, this is another key component. The patient is coming up with their own reasons why they need to change. The change is motivated by a discrepancy between the patient's perceived goals and values versus their current behavior. So again, if a patient has a goal of reducing or stopping their substance use, and so that is their perceived goals and values, their current behavior could be that they're still using their substances. So again, the change will be motivated by the discrepancy in those two situations that the patient has described. Rolling with resistance. So resistance is a signal for the healthcare provider to respond differently. Invite new patient perspectives, and again, when there's resistance, you want to make sure that the patient is providing the reasons for their change, and the patient is providing answers and their own solutions. Support self-efficacy. Patients' belief in possibility to change is a key motivator. The patient is responsible for achieving their own goals, and us as the healthcare provider are there just to support the patient to help them achieve their goals that they have stated. So key MI skills include something acronym called OARS, which stands for open-ended questions, affirming and supporting, reflective listening, and summarizing. So whenever we're asking questions with the patients, we always want to ask open-ended questions. So we're avoiding yes or no or one-word answers. So by asking open-ended questions, we are encouraging the patient to express their own views. So a yes or no answer would be, have you experienced any negative consequences from drinking? Versus an open-ended question, which would be, what negative consequences have you experienced as a result of your drinking? So we're affirming and supporting. So we are actively listening for patients' strengths, values, aspirations, and positive qualities. And then once we listen for those qualities, we reflect those qualities back to the client in an affirming manner. So an example for that would be, you were able to lose weight before because of your perseverance and determination. Those strengths can help you quit smoking. Reflective listening is mirroring what the patient says in a non-threatening manner. It's collaborative and non-judgmental, and it helps to deepen the conversation. It helps the patient understand themselves and avoids over or understating. So again, an example of reflective listening would be, it sounds like you are afraid you might go through withdrawal when you taper your dose. And finally, there is summarizing. So interim summaries throughout the conversation can be used. And when you're finished with meeting with the patient, the meeting ends with strategic collaborative summary. So an example may be, let me see if I understand you clearly. You don't want to stop your opioids, yet you find they are no longer as effective as they once were. Is that correct? So there's also change talk in terms of motivational interviewing. So the change talk can involve preparatory or implementing. And again, the acronym would be DARN CAT. So the D stands for desire. So it's the patient's statements of wants or needs. So the desire would be, I wish I could cut down on how often I use heroin, or I want to stop snorting my pain pills. A stands for ability. So this is what the patient feels that they can do. Example would be, I can meditate every morning instead of taking my clonazepam, or I think I can limit my pain pills to four pain pills per day. R stands for the reasons. So these are reasons why change would be helpful. So you may hear something like, I know if I didn't buy cocaine twice per week, I can use that money for food, or I should change so I can live long enough to enjoy my grandchildren. N stands for need, which is the obligation to change, which is often a more emotional reason. So examples you might hear would be, if I don't stop smoking, I won't be able to hold my granddaughter. Or if I stop using drugs, I can get my son back. So strategies to encourage change talk include asking evocative questions, exploring the decisional balance, looking back what is beneficial about their current behavior versus what are the downsides to your current behavior. What would the future be like if you change? And you can use something called change rulers. So those would be helpful. Change rulers are helpful for assessing importance, confidence, and readiness for change. So examples of that would be on a scale of 1 to 10, how important is it? Or how confident are you? So again, depending on the number that they give you, you can explore that more. So if they said 4, you would ask why did you give a rating of 4 and not 1? And also, what would it take to change 4 to 6? So when we are applying MI in practice, we use an ask, provide, ask. So we're asking them a question, provide input, a response, and then again asking another question afterwards. The key is to be empathetic, non-judgmental, and speak in a neutral way. Speak in the third person, and you can use might, perhaps, consider. And how does this fit in with their own desires that they've stated to you? And then importantly, summarize and guide with a plan at the end of the discussion. Again, when you're using MI, we've discussed this, it's important that the patient is the one making the final decision. So you're providing them help, summary, and guidance, but the patient is the one that is making the final decision. And again, I stated that it may not be the decision you agree with, or you may feel that that's not the best decision for that patient, but again, the patient is the one making that decision, and you're working with them on their own goals. And again, with specific to their goals, it's important for their goals to be SMART goals. Use brief encounters. So again, when we're going through all this information with MI and using it in your own practice, it can seem overwhelming at first, but it's important to remember that brief encounters using MI are effective. So again, depending on your area of practice, if you work in a community pharmacy, just speaking with the patient for a couple minutes when they come in to pick up their medications, that can be effective if you are consistent with those techniques, and efficacy improves over 2 to 3 sessions. So again, as you have these brief interactions of MI, it can be more and more effective over time. So a little briefly about SMART goals. So again, we want patients to have goals, but we want those goals to be SMART goals. And what are SMART goals? They stand for specific, measurable, attainable, realistic, and time-based. So the idea behind SMART goals is that if a patient is explaining goals that are vague, unquantifiable, irrelevant, there's a chance that they may not be able to achieve some of those goals, which may lead to anxiety, uncertainty. So avoiding those type of goals, you want to make sure that they have SMART goals, which are objective way to measure functional progress. It'll show commitment regarding their decisions, and having them set SMART goals and achieve SMART goals will help to create trust and collaboration between you and the patient. So finally, we're going to just finish this section with 2 clips of examples of motivational interviewing. The first clip will be an example of ineffective motivational interviewing, and then the next clip following will be an example of effective motivational interviewing.
Doctors, nurses, and physician assistants all have opportunities to counsel patients about health-related behaviors. As a medical professional, you have a responsibility to talk to your patients about tobacco use and how it affects their health. At times, you will also have a responsibility to talk to them about how secondhand exposure to their tobacco smoke affects other people's health. These can be sensitive topics, and it is important to keep in mind that the way you approach your patients about these issues will have a big impact on how your advice and concerns are received. In general, it is not useful to confront or scold your patients about their tobacco habits, as that approach is usually not well received by patients and may interfere with your ability to counsel them effectively. Watch what happens as this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard, so I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. I mean, everybody has problems, right? It's just really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll find, I guess I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
By starting the interaction with an accusatory question, "Are you smoking?" The provider immediately put this parent on the defensive and minimized the likelihood of a productive discussion. She then proceeded to lecture and scold the parent repeatedly, while ignoring the parent's multiple remarks regarding her low confidence in her ability to successfully quit smoking. Once the parent felt completely defeated, she caved in and announced that she would quit smoking. It is clear to any observer that this parent had no intention to quit smoking at this time, but rather that she was simply attempting to bring an end to the uncomfortable confrontation. In this case, the provider wasted an excellent opportunity to work with a mother who was expressing a real desire to quit smoking, coupled with a lack of confidence in her ability to do so. By listening to what the parent was really saying, the provider might have been able to help this parent develop a workable plan. In addition, both the provider and parent would have felt more satisfied with the interaction. Watch what happens this time when the provider cues in to what the parent is saying, empathizes with her situation, and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that. All the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what? I'm not going to risk that. Mm-hmm. So
the risks were so scary then that you were able to stop. But they don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
you're doing the best you can do.
Yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure, it feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
This time, the provider had the same agenda, to talk to this parent about the dangers of secondhand smoke and to counsel her to quit smoking. However, this time the provider's focus was on the parent's own view of the issue. By giving the parent an opportunity to reflect on her situation, the provider was able to elicit reasons for change from the parent herself. There was no need to lecture or scold because the parent was making her own case against smoking. Many times, our patients already have the information that we try to give them. What they really need is someone to listen to them and to help them sort out a plan that will fit in their life. By accepting and respecting our patients, even with their faults, we communicate our genuine desire to help them make positive changes in their lives. During this interaction, the provider demonstrated that she understood the parent's struggle and that she still wanted to help. As a result, this single parent found she finally had someone on her team. This increased both her interest and willingness to try working further with the provider to find a solution that would fit in her life.
Okay, so